بسم الله الرحمن الرحيم وأصلي وسلم على المبعوث نبينا محمد صلى الله عليه وسلم وعلى آله وصحبه ومن تبعهم بإحسان إلى يوم الدين أما بعد. Today I'm going to be giving a very brief introduction in regards to renal tumors in more of the aspect of benign and also malignant, but in more depth in regards to the malignant, inshallah. To start with, I'm going to be talking about the benign tumors. I put in 5 different classes. You should at least familiarize yourself with the first 3, and that would be the renal papillary adenoma, angiomyolipoma, oncocytoma. Now, the most common benign tumors in the kidney would be the renal papillary adenoma. They were also called cortical adenoma. You should know that these are very small in size, less than 1 centimeter in diameter, and you need an autopsy to check for it. In regards to angiomyolipoma and oncocytoma, I'll be talking about them very shortly in depth. And in regards to fibroma and hamartoma, you should know that these are also benign tumors and they are very small in size. And one differentiation between this and renal papillary adenoma, as we mentioned, is that these would fall under the pyramids of the kidneys. In regards to angiomyolipoma, as I mentioned, this is a class of benign tumor. And you might wonder and ask me, oh Muhammad, what does angiomyolipoma consist of? I tell you very simply, look at the word itself. Angio meaning vessels, myo meaning smooth muscle, lipo meaning fat. So now we know 2 things. Angiomyolipoma is a benign tumor and it would consist of 3 components that we could easily know from the word itself. These 3 components are vessels, smooth muscle, and fat. Now I attached 2 microscopic pictures on the right that would consist of these 3 components. A very high yield information that you should know about is that a quarter or a half% of patients, 25 to 50% of patients with a rare genetic disease known as tuberous sclerosis, they would most likely come with angiomyolipoma. They would most likely have angiomyolipoma. Now, in regards to this rare genetic disease, this is associated with a lot of benign tumors in the brain, in the kidney, in the heart, in the eyes, the skin, and the lungs. In regards to renal oncocytoma, as I mentioned, this is a class of a benign tumor. We should note its origin, and it arises from the intercalated cells of the collecting ducts. Now, I'm going to be talking about the gross features and the microscopic features. In regards to the gross features, please look at the figure on the left-hand side, labeled A, right over here. Now, I'm going to mention 4 gross features. You should at least know 2, and one being the most important feature, and it's that it has the central scar right over here, the central stellate scar, the central fibrosed white area. You can see the figure below, right over here. And on the MRI image, I'm circling right here. Now, the second feature we could mention is that it is a very well circumscribed mass. It's encapsulated. So the third feature, it's that it's encapsulated. And the fourth, we would know about its color. We could say a mahogany brown to yellow in color. In regards to microscopic features, there's not much, but there's 2 features that you should note. And it's that there's a lot of eosinophilic cells and there's a lot of mitochondria, hence why they would appear pink on the right hand side on the figure. Now, one key feature that you should know and you should look out for, and it's that microscopically there is no perinuclear clearing. Now, if there was perinuclear clearing, this would signal another type of disease known as chromophobe renal cell carcinoma, in which I will be talking about very closely. Now, okay, in summary, renal oncocytoma, it's benign and arises from the interstitial cells of the collecting ducts. Now, gross features, what is it? We noted 4. So, it is encapsulated, it's well circumscribed, and about its color, brown to yellow. And the most important feature, central stellate scar. Microscopically, eosinophilic cells with a lot of mitochondria without perinuclear clearing. If there was perinuclear clearing, this would signal chromophobe renal cell carcinoma. The patient with renal oncocytoma would usually present with the special triad of renal carcinoma. That would be the painless hematuria, flank pain, and abdominal mass. We finished with the benign tumors. Now we're going to move on to the malignant types of tumors. Renal cell carcinoma. Why? Because it is the most common type of renal malignant tumors. It mostly affects males between 50 to 70, and smoking and obesity would increase its chances, would increase its incidence. And in regards to these types of tumors, they would secrete a lot of hormones correlated with the kidney. For example, the kidney releases renin, erythropoietin, and parathyroid hormone. So they would secrete a lot of these types of hormones, and this would signal very bad diseases. For example, renin would signal hypertension. An increase in renin would signal hypertension. An increase in erythropoietin would signal polycythemia. An increase in parathyroid hormone would signal hypercalcemia. You could learn it by this mnemonic pair: P being parathyroid, E being erythropoietin, A being adenocorticotropin hormone, R being renin. And there are many subtypes under renal cell carcinoma. For example, clear cell, which is the most common subtype. Now, these subtypes, they are known because of different microscopic features that I'm going to be talking about in the very few next slides. And in regards to its presentation of renal cell carcinoma, just know that simple triad, and it's that hematuria, palpable masses, and flank pain. These are the three most important presentations of the patients that would come with renal cell carcinoma. And in regards to the treatment, simply surgery or immunotherapy. And it could either spread by lymph nodes, for example, by the para-aortic lymph nodes. It could spread by blood, by metastasizing to the lung and bone, or it can spread directly and invade the renal vein, so they would go and invade the inferior vena cava, and this would signal a very bad end stage of the tumor. So in regards to the classification of renal cell carcinoma, as I mentioned in the previous slide, that clear cell carcinoma, it is the most common subtype of renal cell carcinoma. There's also other subtypes, for example, papillary carcinoma, chromophobe renal cell carcinoma, and collecting duct carcinoma, also known as the urothelial carcinoma. So these four would fall under renal cell carcinoma. Now, just to give a very quick summary in regards to what renal cell carcinoma is and what I mentioned, so you would correlate it with these four subtypes. So renal cell carcinoma, as we mentioned, it is the most common type of malignant renal tumor. The patient would come in and complain with the famous triad that we mentioned, for example, hematuria, flank pain, and palpable masses. And in renal cell carcinoma, as I mentioned, they could spread by three ways: by blood, or by lymph node, or by direct contact. And in regards to direct contact, they would affect the renal vein, and they would go up and affect the IVC. And in regards to the blood, they would affect the bones and the lung. And in regards to the lymph nodes, they would affect the para-aortic lymph node. Now let's move on and explain the clear cell carcinoma. In regards to clear cell carcinoma, I'm going to be talking about its growth features. Very important growth feature is that it affects the renal poles. This is important clinically too, because it is away from the renal pelvis, and so there would not be any signs of hematuria in the beginning. Secondly, it is usually unilateral. Thirdly, there's yellow spherical masses because of the lipid accumulation in the tumor. As you can see here on the right, I attached two figures. So the picture above is affecting the upper pole of the kidney. As you can see here, wait, I'm circling it right over here. And the picture below is affecting the lower pole right over here. Now, in regards to microscopically, as we mentioned, clear cell carcinoma. So by its name, clear. So there is clear cytoplasm. So three features that you should know about: clear cytoplasm, central nucleus, and branching of the blood vessel. So if we look into the microscopic picture, for example here, and these are the blood vessels, so they would be branching. And this would give a very well-known appearance known as the chicken wire-like. So in regards to papillary renal cell carcinoma, they are less common than clear cell carcinoma. As I mentioned, that the clear cell carcinoma is the most common subtype of renal cell carcinoma. So papillary renal cell carcinoma is less common, and they would just show papillary pattern. and very important features, and it's that they are multifocal and bilateral. And you can see in the figure below, you should know that these are lined by malignant epithelial cells right over here, and inside would be the interstitial foam cells. In regards to chromophobe renal cell carcinoma, I won't be taking much time in regards to this type of carcinoma because they are very similar to oncocytoma. So you could say chromophobe renal cell carcinoma and oncocytoma, these are hybrid tumors, and they might be seen in this type of syndrome known as Birt-Hug-Dube syndrome. And microscopically, as I mentioned, it's the same thing as oncocytoma, so they would arise from interstitial cells, the collecting ducts. And as we mentioned in oncocytoma, they are made up of eosinophilic cells. But one key feature that we mentioned earlier on in oncocytoma, and it's that they would have the perinuclear halo, so the perinuclear region that we mentioned. So if there would be perinuclear region, this would signal chromophobe renal cell carcinoma. Grossly, as I mentioned, same thing as oncocytoma. Uh, well circumscribed, the cut surface usually yellow or brown with a central stellate scar. You can see the central stellate scar right over here. All right. Well, last but not least, the last subtype of renal cell carcinoma, the transitional renal cell carcinoma, also known as the urothelial carcinoma. Now, I'll just be mentioning it as urothelial carcinoma. So in regards to urothelial carcinoma, one important feature that we should note down, and it's that it originates from the urothelium of the renal pelvis. Now, when I mention renal pelvis, your mind should right away go signal in regards to clinical aspects. Now, in renal pelvis, we should know that if the renal pelvis is affected, this would signal right away hematuria. So when the tumor is originating from this source, the patient would come in within short amount of time complaining in regards to hematuria. In contrast to clear cell carcinoma, in which the tumor was arising from the poles of the kidney. So the poles of the kidney, they are away from the renal pelvis. So the patients with clear cell carcinoma wouldn't come complaining in short amount of time right away in regards to hematuria. It would be delayed. And in regards to urothelial carcinoma, it could be multiple and it could affect the ureter and bladder. Now, bladder is very important because most of the time, 50% or more of urothelial carcinoma, they would come with pre-existing urinary bladder tumor. In regards to Wilms tumor, also known as nephroblastoma, you should right away remember that whenever the word Wilms tumor or nephroblastoma mentioned, خلاص, correlated with children. That's it. So Wilms tumor, childhood, between 2 to 5. Very rare cases for it to be bilateral. Yani most of the times it's unilateral, and it has very good prognosis. In regards to gross features, I just want you to mention and remember two gross features. One being that there is a large, well circumscribed mass. Look on the right hand side, the figure right over here. This is the large tumor mass. It is unilateral also. And the second feature that you should note down, and it would be homogeneous. So all in all, three features. So large, well circumscribed mass, most likely unilateral. Third would be homogeneous. In regards to microscopic features, three components. Very simple, very easy, very straightforward. To begin with, blastomal component, second, epithelial component, third, stromal component. To begin with, blastomal component, just know that these are composed of a lot of small blue cells, and the epithelial components, they are just epithelial cells trying to form the tubules or the glomeruli, but they are failing to do so. Like, they're very poorly formed tubules or glomeruli. And stromal components, just a lot of whatever. يعني حرفيا just a lot of whatever. Could be either a lot of areas of fat, or cartilage, or bone, or skeletal muscle. Literally whatever. So the microscopic figure on the bottom right, I'll just be highlighting and explaining. So the blastomal component, as we can see here, this. So this would be all blastomal component. All this, so a sheet of blue cells. In regards to epithelia, you can see this small little border. They're trying to form, for example, the tubules, but they're failing to do so. This would be the epithelial component. and the stromal component is the spindle cell stroma. خلاص, this is whatever, literally the background forming either the cartilage, the bone, the skeletal muscle, or whatever. But not least, we have the metastatic tumors of the kidneys. You should know that this is very uncommon to happen and it is very rare. And in regards to the gross features, I'll be mentioning 5 gross features, and in case if it would come in your OSPE. So to begin with, I'll just be circling some masses. For example, here, here. So what can we see? We can see multiple masses. They are irregular and they are affecting both kidneys. So that's 3 features already. So multiple irregular bilateral masses. The 4th feature would be is that we could see some black discoloration right here, some black discoloration right here. So this would signal melanoma. We could write it down in that, yani, when they ask about the diagnosis. And in regards to the 5th feature, and it is the most important feature, and it's the umbilications, the central indentations, which are present right over here. I'm circling it. This is because of central necrosis that happened, and so there's no blood supply towards the center, so the center would just show a hole, and they usually call it umbilications. So these are the 5 features that you could see in metastatic tumors of the kidney. Alright, alhamdulillah, we are done with the pathology lecture of renal tumors. I hope that was easy. I hope everything made sense, and I hope you study the lecture now efficiently or recall the information in a better manner. And in regards to the picture that I attached, I just wanted to give a very gentle, brief, quick reminder in regards to dua. Since we are in the holy month of Ramadan, يعني شباب وبنات يعني لا تنسون إنه تزيدون من دعواتكم. Don't forget to make dua for yourselves, for your family, for your close ones, for your loved ones. There are a lot of virtues mentioned in regards to the person making dua when he's fasting, or for example when dua when he's in sujood, and specifically يعني أصلا in the holy month of Ramadan. For example, the narration of for example the Prophet ﷺ mentioned ثلاث دعوات لا ترد: دعوة الوالد ودعوة الصائم ودعوة المسافر. دعوة الصائم يعني most of the time يعني خلاص نحن برمضان نصوم، لا تنسون يعني تدعوا لي، الله يخليكم، محمد الخالدي الاسم. ويا سبحانك اللهم وبحمدك، أشهد أن لا إله إلا أنت، أستغفرك وأتوب إليك.